you very much for starting off such an incredible meeting. I learned a lot from you, and I was lucky to have met you a few months ago. I will be covering a series of different topics in relation to twin pregnancies. And then if people want to ask specific questions, we will address them now, at the end of this lecture, or in the afternoon. I will divide my lecture into two. Some of the topics will be covered this morning, and then some others later on this afternoon. So let's start off. The issue of zygosity and chorionicity. Let me just take you through this. I hope it's not too complicated. Dizygotic twins, we start off with 2 eggs and 2 sperms. And all of the dizygotic twins, non-identical twins, are also dichorionic. They have separate placentas. If we take the monozygotic twins, we start off with 1 egg and 1 sperm, and the cells divide to a certain point, and then they split up to produce 2 babies. So they are monozygotic, and they can be dichorionic, 2 placentas, or monochorionic. And here is where I talk of the principle of 3. If I take the monozygotic twins, 1/3 of them will end up being dichorionic, because the tearing apart of the single cell mass into 2 occurs within 3 days of fertilization. So if you have splitting up within 3 days of fertilization, we have dichorionic monozygotic twins. And on the right, you can see the different stages of splitting. Splitting within 3 days gives you 2 separate placentas, and of course 2 sacs. Splitting the subsequent days, right up to day 9, you have the same sharing of the placenta, but you have 2 amniotic sacs, monochorionic, diamniotic. If you hang on for 9 days before you split up, then we can have monochorionic in the same sac, monoamniotic. And if you wait for 3 more days before you try to split up, you never split up. So if you're going to split up in any relationship, try to split up as early as possible. Otherwise, you're stuck together forever. And that is the principle here. Now, in the early 1990s, when I suggested that if we look at the back of the neck of a fetus in the 12th week of pregnancy, and we could measure the fluid behind the neck, we could suspect that there may be an increased risk of a chromosomal abnormality, a cardiac defect, or any other genetic syndrome. So suddenly, ultrasound scanning from 16 to 20 weeks had begun to move to the 12th week of pregnancy. And at that time, this guy from Chile, Waldo Sepulveda, was my research fellow, and he described the differences between monochorionic on the right and dichorionic twins. It was quite easy, really. You could have the placenta, which is this grayish part on the right, extending into the base of the intertwin membrane. And that was dichorionic. If instead of having that sign that we called the lambda sign, you had this sign where the membrane came directly onto the placenta without this intertwin extension of the placenta, that was mono, oh dear. What has happened now? Okay, that was monochorionic. We did several studies after that, and we followed up the women at 16 weeks and 20 weeks. And by that time, quite a few of the cases where you had this intertwin extension of the placenta by 16 to 20 weeks. That extension was not obvious, and therefore you could make a mistake at 16 and 20 weeks that you could avoid by doing an ultrasound scan at 12 weeks. In the subsequent years, from 1992, when I first described this nuchal translucency scan at 12 weeks, the 12-week scan became established for all of the hospitals in England. So in about 2% of pregnancies, we could diagnose twins, and it was the ideal time to determine whether the pregnancies were dichorionic or monochorionic. And this was of critical importance in defining the subsequent course and management of these pregnancies. There you are. The placenta extends into the base of the intertwin membrane, and here, and that's the lambda sign, and here you don't have that. So it's very easy to distinguish between the two, provided you know where to look. Everything is easy if you have had adequate training to know what to look for. And Sarah has mentioned already the necessity of people to receive extensive medical obstetricians to receive extensive training in the diagnosis and management of twin pregnancies. And it is not good enough to say that because in each hospital we have to have somebody responsible for the management of twins, automatically that person is competent. What is much preferable is that unless somebody is super skilled and extensively trained in the management of twins, is to refer all of these patients to a tertiary center. Let me now go to the right to clarify one issue. If we start off with 9 twin pregnancies, 1/3 are monozygotic, identical, and 2/3 are dizygotic. All dizygotic have 2 placentas, top left. Of the monozygotic, 1/3, where the splitting will occur within 3 days of fertilization, will also be dichorionic. So if you do an ultrasound scan and you see what you can see in the bottom of on the left, then that is a monochorionic pregnancy and always monozygotic. But if you see this lambda sign, where the pregnancy is dichorionic, 6 out of 7 are dizygotic, non-identical, but 1 out of 7 is still identical. So chorionicity, where you say there are 2 placentas, does not imply that the babies are not identical, but 1 in 7 will still be identical. Let's now go to another topic. How do we date the pregnancy? Now, unfortunately, in 1 in 3 cases, women will get pregnant while taking the pill, or they will have had irregular periods, or they were breastfeeding when they got pregnant, and therefore their dating of the pregnancy is quite inaccurate. It is therefore the case that I suggested from 1992 that whenever we diagnose twin pregnancy, it is best to measure the crown rump length of the babies. And then on the basis of this size of the baby at 12 weeks, we should be dating the pregnancies. Except perhaps when the women conceived by IVF, where it was certain when they got pregnant. Now, in the time in 1992, I said, if we have twins and one baby is bigger than the other, we should be using the size of the bigger baby to date the pregnancy. My rationale at the time was that the small baby may be smaller because it may have an abnormality, and it would be wrong to use an abnormal baby to date the pregnancy. So impulsively, I thought it was best to date the pregnancy on the basis of the size of the bigger baby. And here is what the various organizations have recommended since. This is the American College of Obstetricians and Gynecologists, who said that nothing, they didn't recommend how to date the pregnancy. We have the obstetricians in Canada who said that we should use the dates in women that had IVF from the IVF, and in spontaneous conceptions, we should use the size of the bigger baby to date the pregnancy. And then we have the Royal College of Obstetricians in England, which says that it doesn't really matter whether you conceived by IVF or spontaneously, you should always use the size of the bigger baby to date the pregnancy. A lot of these decisions were sort of impulsive without any real scientific basis, as indeed my decision in 1992 to say use the bigger baby was just my thoughts at the time. Recently, I asked one of my ex-research fellows who works in an IVF center in Bulgaria, an excellent fellow that was with me for 3 years, to look at all of the IVF pregnancies that they had. And then we looked at the size of the two fetuses and tried to work out which was more representative of the date of conception that was known from IVF. On the left, you have the size of the larger baby. The blue line is where we should be with all of our measurements. This should be reflective of the truth. And you can see that if we use the size of the biggest baby, we are actually overestimating the gestational age. So 30 years later, I am prepared to accept that I was wrong in my recommendation of 30 years ago, and that we should be using the size of the smallest twin at 12 weeks, where you see it fits better on the blue line, rather than the largest twin in the calculation of the gestational age. Nothing very intelligent, but the truth. So in the calculation of the gestational age, in a twin pregnancy, whether conceived by IVF or spontaneously, it is best to assess the gestational age from the crown rump length of the smaller of the two twins. Because my original fear of doing so, that we may be using a baby with a serious abnormality to date the pregnancy, a compromise solution is to use the average of the two babies for the calculation of the gestational age. And that is what I will be recommending now. And I'm sure in years to come, the various colleges will change their recommendations. So if you want to date the pregnancy of twins accurately, at 12 weeks, we take the size of the two babies and use the average to date the pregnancy. Of course, this has major implications, because if we get it wrong, then we can overestimate or underestimate the gestation. We will get caught up with problems later on in pregnancy, where we will be saying, this baby is not growing well, or this baby is growing too well. And then we take wrong decisions about management. Let us now address another question, and that is of the labeling of twins. Which is twin 1 and which is twin 2, and does it really matter? Well, the way to label the twins is in relation to the intertwin membrane against the cervix. So if a woman was going to deliver vaginally, the baby that will drop out first is number 1. And obviously, the bottom baby on the right will be the one to deliver first, because it's closer to the cervix. And this relationship of the intertwin membrane to the cervix does not change during the course of the pregnancy. When you do an ultrasound scan and you look at the two babies, sometimes this baby, the top one, may appear to be lower than the baby on the right. So we then mix them up. And it is important not to mix them up, because of several reasons that I will discuss. And always deciding as to which baby is first and which baby is second must depend on this relationship between the membrane and the cervix. Now, why is it important? Well, it is important that 12 weeks, when we are trying to work out what is the chance that one baby has, for example, a chromosomal abnormality. In the case of dichorionic twins, one baby may have a very low chance of having Downs, for example, and another baby an extremely high chance. And when you do the scan, and the person who is doing the scan says, yeah, this baby has a high risk and the other baby doesn't have a high risk, then somebody else, in most of the hospitals in England, an ultrasonographer will do the scan, and then they will be referred to their own obstetrician in charge of the management of these pregnancies, and then we can get things wrong. In what sense? Well, we will go on, for example, in some women where there is a large chance that one of the babies has a chromosomal abnormality, to carry out an amniocentesis or chorionic villus sampling. And then if we diagnose that one baby has a major chromosomal abnormality and the other does not, one of the options of the women would be to do nothing. They're happy to carry on with the pregnancy. Another option is that they would want to have a selective termination. And what a disaster it would be if we failed to label the babies properly, and then we do an embryo reduction of the baby that was not affected by the condition that we were afraid of, and then we leave behind the baby that had the problem. And this has happened all over the world a lot more times than you can possibly imagine. So it is critically important for this assessment of the chance of a problem to be defining the position of the babies properly. Also, the accurate assessment of fetal biometry. Sometimes you do ultrasound scans, and then when you look at the plot of several scans, you get the impression that the babies are changing from small to big. And the reason for that is that with each ultrasound scan, people may not be careful, and they take different measurements of the two babies, and they are mixing them up. And that is very dangerous, because unless you are accurately assessing the babies, you may miss the fact that one baby is not growing well, and that baby may well die, for example, because you made these mistakes of mixing up which is baby one and baby two. And then, of course, once the babies are to be born, you have to pass on the information, the anticipated information that one baby may be big and the other small, to the neonatologist that will be looking after the baby. So it is important to know which baby is one and which baby is two for these various reasons. And it is very easy, especially at 12 weeks, to work out which baby is what. Now, let's go to another topic now. Assessment of the chance that the babies will have a chromosomal abnormality. In all hospitals in England, in singleton pregnancies, we offer assessment of risk for trisomies 21, 18, and 13. And of course, the same is true for twin pregnancies. Is there a difference between the two, singletons and twins or triplets? And what are the differences that we have to be aware of? In dealing with twin pregnancies, it is critically important to address the question of whether the pregnancies are dichorionic, where I mentioned to you before, 6 out of 7 will be non-identical, whether they are monochorionic, where the babies are identical, and whether the pregnancy is what we call vanishing twins, where one of the babies has died. And each one of these types of twin pregnancies has important implications on screening for chromosomal abnormalities. Let us look at maternal serum biochemistry, the BARTS test, or the triple or quadruple test in the 16th week of pregnancy. We are measuring 4 or 3 metabolites, alpha-fetoprotein and estriol, which are below average in pregnancies with Down syndrome. And they're also measuring HCG and inhibin A, which in pregnancies with Downs tend to be above average. When we do this triple or quadruple test in a singleton pregnancy or monochorionic twins, because it comes as a package with singleton pregnancies, the monochorionic twins, because they're identical, then the detection rate of Downs is about 70% in singleton pregnancies or monochorionic twins. But in dichorionic twins, the detection rate is only 40%. So this test is pretty bad for twin pregnancies. And the reason for that is very simple. We have 2 placentas. One placenta is, let's say, abnormal, and it produces low levels of alpha-fetoprotein and estriol and high levels of HCG and inhibin A, suggesting that the baby may have Down syndrome. But because you have the other placenta that is producing a normal amount of these metabolites, the abnormality of the abnormal placenta is diluted by the normality of the normal placenta. And that is why the test is not so accurate in dichorionic twins by comparison to singleton pregnancies. If anybody wants to ask me any questions, please do, and I will answer them at the end of this lecture in relation to this. The 16-week BARTS or quadruple test is not too bad in singleton pregnancies. It's not the best, but it's not too bad, but it's pretty bad in the assessment of risk of twin pregnancies. Let us now look at my test, and that is the nuchal translucency test, where we combine this collection of fluid behind the baby's neck at 12 weeks, here on shown there, the black space behind the neck, nuchal neck, translucency black space. The higher the black space, the greater is the chance that there may be something wrong. Downs, 18, 13, other chromosomal abnormalities, cardiac defects, genetic syndromes. Let us now take a dichorionic twin pregnancy. Another thing that we find in a Downs pregnancy is that the hormone HCG is twice as high in a Downs pregnancy than in a non-Downs pregnancy. And the hormone PAB-A is half as much in a Downs pregnancy than in a non-Downs pregnancy. Now, in a dichorionic twin pregnancy, we look at each baby separately. And as I mentioned before, the nuchal translucency in one baby may be very high, and therefore the chance that the baby would have Downs is a lot higher than in another baby in the same pregnancy where the nuchal translucency is low. In the top left chart of this slide, the red squares are from babies, is the nuchal translucency of babies that have Down syndrome. And the 3 lines at the bottom is the normal range with the yellow dots. And you can see that a lot of the individual fetuses in a dichorionic pregnancy that had a chromosomal abnormality had very much increased nuchal translucency, and that was driving the overall chance of risk. We do include the measurement of free beta HCG and PAB-A, and the same argument applies, as I mentioned before, for the triple test or quadruple test at 16 weeks, where the normal placenta will be diluting the effect on these hormones from the abnormal placenta. So the biochemistry itself is not so good, but because the main element that defines your chance in the nuchal test is the nuchal translucency, then the accuracy of the test in dichorionic twin pregnancies is quite good. And if the detection rate in a singleton pregnancy from this first trimester combined test is about 90%, by classifying 5% of women as being at high risk, in a dichorionic twin pregnancy, we can achieve the same 90% detection with a slightly higher false positive rate because of this biochemical problem. But the effect is small. Instead of classifying falsely 5% of women as being at high risk as singletons, in the dichorionic twins we classify 6%. So it's just a bit worse, but not too much. Let us now look at the bottom left hand corner, where we are dealing with monochorionic twins, by definition, identical twins. If one baby has Downs, for sure the other one will also have Downs. And if one is normal, then the other one must also be normal. The red squares again are from Downs babies. And because here we have two identical babies, I am joining the red squares of the two babies within the same pregnancy. There will be some pregnancies where both Downs babies have high nuchal translucency, but in quite a few of them, one of the Downs babies may have a high nuchal, very high nuchal, and the other may have a very low nuchal. How come? Well, this is the interesting thing about monochorionic twins, because you can have a high nuchal, not only because you may have Down syndrome or another chromosomal abnormality, but because you are the recipient of an early sign of twin-to-twin transfusion syndrome. If you are the recipient, you are receiving too much blood, and you have an element of heart failure. And when our grandmother gets heart failure, she gets swelling of her ankles. But when the fetus gets heart failure because they're lying down, the area where they will get swelling is not their feet, but is the neck. So a high nuchal translucency in a monochorionic twin pregnancy may be a sign of a chromosomal or other abnormality, but it could also be an early sign of twin-to-twin transfusion syndrome. In such case, one of the two babies is a bit bigger than the other. It has increased nuchal translucency, and the other is a bit smaller with a low nuchal translucency. And if you have experience, and that's why it is critically important that these patients are seen in a super specialist center or in a center with a great expertise in the field, then you look at the membrane that separates the two babies, and you can easily demonstrate that already the amniotic fluid in the recipient is bigger than in the smaller baby where there is reduced amniotic fluid. And also, you can look at the bladder of the two babies and the recipient, which receiving blood, and in response to receiving blood, it pees more, the bladder is bigger. So higher nuchal, bigger baby, more amniotic fluid, and a big bladder strongly suggests that we have early signs of twin-to-twin transfusion syndrome and not Down syndrome. Therefore, in a monochorionic twin pregnancy, in order to achieve the same detection rate of Down syndrome of 90% as in a singleton pregnancy, the false positive rate is not only 5% anymore, but it's almost twice as much, exactly because the nuchal translucency could be wrongly increased nuchal attributed to Downs, whereas in reality it's a sign of twin transfusion syndrome. I can discuss this more if anybody wants to do so. Now, in the recent years, in the last 10 years, we had this cell-free DNA test, the NIPT, the cell-free DNA test in the mother's blood. The placenta contains a lot of cells and is a very actively dying and rejuvenating, growing organ. It almost behaves like cancer, the placenta. The DNA from the cells that die, the DNA is normally in the center of is in the nucleus of the cell. But when the cell dies, the nucleus disperses and the DNA that is contained within it breaks up into fragments, and these fragments are released from the cell and they enter the surrounding fluid. And that is why we refer to it as cell-free DNA. It's DNA outside the cells. The placental cells that are dying are releasing the DNA that they contain into the maternal circulation, and a lot of the cell-free DNA in the mother's blood comes from the placenta. And we have exploited this knowledge in the last 10 years, and we can analyze this cell-free DNA and work out what is the chance that the baby will have trisomy 21 or other chromosomal abnormalities. We have carried out extensive studies in singleton pregnancies on the left. And a few years ago, Mark Gill, a Spanish research fellow that was working with me, we put together the results from our studies together with those reported in the literature, and we gathered nearly 2,000 pregnancies, 1,963 pregnancies where in a singleton pregnancy, the baby had Down syndrome. And we saw how accurate is this analysis of the cell-free DNA in the mother's blood in the detection of Down syndrome, and it was extraordinarily good. The detection rate was 99.7%, not 100%, but nearly. And the false positive rate means that we say that the baby has Downs, but it does not, was 0.04%, less than 0.1%. With all of our previous tests, including my own, the nuchal test, the detection rate was about 90%, and the false positive rate was 5%. So this, I have to admit, was a hell of a lot better than what I described in the early 1990s. And this has now become part of the routine offer in all pregnant women in England that have a high risk from the combined test. So all women in England are offered my test, the nuchal test, and if the risk is very high, more than 1 in 150, then they have the option of having an invasive test, amniocentesis or chorionic villus sampling, or alternatively, they have this non-invasive cell-free DNA test, which gives you almost as accurate a result as if you had an invasive test. The number of cases of trisomy 18 was less, and the number of cases of trisomy 13 was even less, to give precise estimates of the accuracy of the test. Nevertheless, it appears from even this small number of cases that the test is quite good for the detection of trisomy 21, 18, and 13 in singleton pregnancies. Now, let us now compare that with twin pregnancies. I put together all of the cases that we had seen by another research fellow, this is Hannah Judah, and we combined the data with the whole literature, and we came up with the pathetic number of 137. I mean, I call it pathetic because by comparison with singletons where we had 2,000 cases, Here we had just a bit more than 100. So we cannot be as confident about how good the test is in twin pregnancies. But if you now look at this detection rate in the middle, also it appeared to be about 99%, but in brackets, we put this confidence. How confident are we that it is 99%? Well, we are more or less confident that it's not too bad, but it could be anything between 92 and 99.9%. I hope you understand what this confidence interval means. When we give a test and we say it is 99% accurate, we are not actually telling the truth. A more true statement is that it can be between 92 and 99.9% accurate, because the numbers that we're using are very small. In trisomy 18, the number of cases that we had was pathetic. We only had about 50 cases. And although the accuracy of the test was about 92.8%, look at the brackets now on the right. How confident are we? Well, not very confident, because it could be anything between 77% and 98%. And then trisomy 13, even worse, 11%. And what does that mean? Depends on how much of a lie you want to give to the women. You can say it's really good. It is detecting 94.7% of the cases, but the real truth is that it may detect anything between 9 and 99.9%. So it's anybody's guess. What is my conclusion? Because we cannot be dismissive of everything. I think for a woman with a twin pregnancy who is 45, and she's 45 because she couldn't get pregnant before, and as the years go by, her risk of having a Down's baby goes up, and now she managed eventually to get pregnant. She does not want to have an invasive test, but how reassuring can it be to such a woman to offer her this cell-free DNA test? Well, I can be quite reassuring. I can tell her that it would be quite good with a detection rate of more than 90% for Downs, but not so accurate for the detection of trisomy 18 Edwards syndrome and trisomy 15 Patau syndrome. The good thing about trisomy 18 and trisomy 13 is twofold, and I hope that you don't misunderstand what I will say now. Unlike Downs, where the baby is going to be born and live for at least 60 years, and for a couple that don't want to have a Downs baby, tough luck. They will have to put up with it for 60 years at least. In the case of trisomy 18 and trisomy 13, if we miss it and they are born with these chromosomal abnormalities, the condition is self-limited. They will not live for too long, and therefore they will not suffer for a long time, and the parents will not be subjected to the trauma of having to look after two severely handicapped babies. The second thing that is good about trisomy 18 and 13, in a sense, is that they have many, many fetal abnormalities that you can relatively easily see by an ultrasound scan at the 12th week of pregnancy. And that is why it is critically important in twins that the women are seen in super specialist centers, where they don't just do a quick scan to measure the size of the baby and the fluid behind the neck, but they do a very detailed ultrasound scan to look for a series of fetal abnormalities that are characteristic of trisomies 18 and 13. So, conclusion, yes, we can offer these women a cell-free DNA test. We can tell them that the results for Downs are quite good, but the results for trisomy 18 and 13, we do not know how good they are. But if they are seen by a specialist who would do a detailed ultrasound scan, then you can get a relatively good assessment of the likelihood that they will have a baby with one of these chromosomal abnormalities. And then we come to this condition called vanishing twins. You can see on the graph on the right, on the feed photograph on the right, which is a 3D ultrasound image, the baby at the bottom and another baby at the top, which is extremely small. The top baby has died several weeks ago. Can we perform a cell-free-DNA test in this pregnancy? The answer is, unfortunately, not, because the dead cells from the dead fetus that are entering the maternal circulation, they're overwhelming the DNA that is in the mother's blood that has come from the pregnancy. So if the baby that has died has done so because it has trisomy 18, for example, we will be finding a hell of a lot of DNA which says I have trisomy 18 in the mother's blood, but the normal baby at the bottom, whose placenta is healthier and therefore produces less DNA to enter the maternal circulation, will receive the false information that that baby may have trisomy 18. Let me repeat, the test, the cell-free DNA test in a twin pregnancy where one of the babies died is quite inaccurate because most of the information that is coming in the mother's blood comes from the dead fetus, not from the live fetus. So unfortunately, we cannot use the cell-free DNA test for at least 15 weeks. So if one of the embryos has died on week 6, we cannot use the cell-free DNA test until 21 weeks. That's that. What about the combined test? What about the nuchal translucency test? Well, that is also interesting. One baby is alive, the other baby has died. The dead fetus does not affect the measurement of the nuchal translucency. The dead fetus also does not affect the measurement of HCG, the pregnancy hormone. As soon as somebody dies, the placenta dies, and the HCG that comes from that placenta is 0. So whatever HCG you measure in the mother's blood comes from the living placenta. And therefore, we can use the nuchal and we can use the HCG. But look in the middle of the graph, what happens to PAB-A, the second hormone in the first trimester combined test. The PAB-A is higher several weeks after the fetus has died. So the PAB-A is inaccurate. So you can use the first trimester combined test for the assessment of risk of Downs, but only if we use nuchal translucency and HCG, not PAB-A. I have now run out of my allocated time, and I will stop, and then we'll continue with the other aspects of the twin pregnancies later on. So Sarah, back to you.
So we've got Jeanette. Do you want to open your mic and ask Kypros your question?
Yeah.
Jeanette, talk now.
Hi, Kypros.
Hi, Jeanette.
I trained as a midwife at Queen Mary's in Sidcup in 1990, so your name was very well known then. We used to refer all the fetal medicine cases to you. You were a bit of a known person then, so you've been going a long time, and it's lovely to be at a symposium with you. So I was just wondering about the sizing and dating of the pregnancy. Is it because you talk about the inaccuracy with the larger fetus? Is that because there may well be twin-to-twin transfusion already, so you've already got disparity in the sizing?
Very good question. Thank you. That is an obvious explanation in the monochorionic twins. The problem is that was also true in the dichorionic twins. So I wonder whether actually in the context of IVF, somehow in the beginning, we know that with IVF pregnancies, you have a higher risk of a small baby later on, but it may well be that in an IVF pregnancy, somehow the size of the fetus at 12 weeks is above average. That's the only explanation we have, really, that the IVF pregnancy in that model was stimulating a bigger than expected size of a baby. That is for the dichorionic. For the monochorionic, you're absolutely right. It could have been a consequence of early onset twin-to-fetus fusion syndrome.
So is there a possibility with, sorry, it's a bit off topic, but with infertility that the fluids and the chemicals used for that actually could have an effect as well on the fetus?
Yes, yes.
Okay.
And we believe so to be the case.
Right.
Yes,
Okay.
Thank you.
Thank you.
Okay, so the next question we've got Yasmin Serpent. Do you want to open your mic and ask a question?
Hi, Kypros.
Hi.
So my video's off because my house is an absolute dump. So I just want to know, well, kind of two questions in one, but you know, the NIPT test, why do you think it's not offered as standard in the NHS instead of the combined?
Okay, that's a different political discussion. Unfortunately, in England, the test is offered to only 2 to 3% of the population. In Belgium, in Holland, in Germany, it is offered to the whole population. The test, when it was first introduced, was costing about £500. A lot of the companies that I have been doing research with can now offer a test for less than £100. I think that it should be offered to a much higher proportion of the population. I would want it to be offered to all of the women. And the cost of the test, I know from some of them, will be less than £50. We have two reasons for not being offered in England. The first one is cost, they say. And although we are one of the most rich countries in the world, we pretend to be poorer than Greece and Afghanistan. The second reason is an ethical one. And listen to this. There is a very vocal group of people with disabilities, Down syndrome and so on, organizations that feel that if we offer the cell-free DNA test to everybody, that would lead to the killing of a lot of the babies with disabilities. I think that that is wrong. I think that there is a dissociation between offering a test to people so they can have more information to decide for themselves as to whether they want to continue with the pregnancy or not, and actually having an abortion. And a lot of the women in England, and an increasing proportion of women in England with a baby with Down syndrome, would want to continue with the pregnancy. So to avoid giving accurate information to women because we will engage in social engineering, I think it is wrong. I hope you get my point. So
Yes,
it is
yeah.
organizations that have passed on the message that by finding out more accurately whether the baby has a problem or not, they're saying we shouldn't give that access to all of the women, because if you do, we don't trust the women that they will take a correct decision and they will kill their babies, and therefore that is biased against disability. I think that is wrong.
Yeah, no, I've definitely heard that point. And then sort of the follow-up question, I mean, you kind of answered it, but I'm still interested to hear if you have anything to add. If a family were to choose NIPT testing, so say they went privately or whatever, and they had the NIPT testing instead of the combined test, would you still recommend that they have a 12-week scan? Say this family wants to limit the amount of ultrasounds that they do, because they're concerned about effects. Would you still should you recommend they have that?
Okay, So this is a very important and very good question, Yasmin, because the NIPT test is giving you information about Down syndrome, or 18 or 13, but the first trimester scan, the 12-week scan, is doing a lot more than that. It is telling you the size of the baby. It is telling you whether the baby has a head or not, whether it has an encephaly. There are many, many major fetal abnormalities that they can be diagnosed at 12 weeks beyond screening for Downs. Also, critically important, if you have a high nuchal translucency, we have a lot of women that come along and they say, I don't want to have an assessment of risk for Downs. I said, perfectly all right. We will not give you a risk for Downs, but please let us measure the nuchal translucency, because if the nuchal translucency is very high, it would indicate perhaps a higher risk for a cardiac defect, in which case we will arrange for you to have a detailed ultrasound examination of the heart, because there are some heart abnormalities that would necessitate that the baby is born in a center with cardiac surgery. And if we were not aware that the baby had a heart defect of that type, then the baby will die or suffer brain damage because it was born in the wrong place. So, Yasmin, two things. Yes, the NIPT test is more accurate than my test, the combined test, but the ultrasound scan at 12 weeks is still quite important for other reasons beyond Downs.